Welcome to this session. We're so glad to have you. My name is Miriam Chickering, and I'm joined by my colleague, Dr. Erica Frank. She's the founder of NextGenU.org, and I'm the founder of Nurses Internationalv.org, and together, we're working to disrupt the healthcare education sector. We've been invited here today to talk to you about some of the opportunities, challenges, and the great potential that awaits all of us in this brave new post-pandemic world where we've all been doing online education for the last year. We want to talk about the challenges, the potentials, and the impacts, not just on your learners, but on your organizations. There's tremendous opportunity for impact at scale. Before I get started, Dr. Frank is going to share our story with NextGenU, and then we're gonna suss that out and talk about how some of the things that we've been doing over the last couple of decades can impact your organization. Dr. Frank.
Thank you so much. Delighted to be here as well. And I'm going to be, as Ms. Chickering said, introducing you to what we've been doing for the last 2 decades to democratize health sciences education. So this is me, Erica Frank. I'm the Canada Research Chair in Preventive Medicine and Population Health at the University of British Columbia, where I'm also a professor and physician, and I'm the inventor and founder of NextGenU. This is our portal. We are still, and have been for the last 2 decades, the only portal to free higher education certificates, and I'll explain to you a bit about what that means. So we have presence in every country in the world and components of the curriculum available in over 100 languages through Google Translate. So I'm going to pause for a moment on this particular slide and to talk about the 3 categories of characteristics that most people like to know about for NextGenU. So these are characteristics that we share with traditional universities. We provide with our partners, which are accredited universities and other accredited bodies, credit for our courses, like you would get with an away elective that you could do. The courses are customizable. They have thorough assessments, both objective and human subjective, and I'll show you a little more about that later. There's higher level education. They're direct human interactions, especially when they're competency dictated. And we have what I like to call warm prestige. We have many of the characteristics, including being able to provide a certificate that traditional universities can have, the prestigious parts, but we also are able to do remarkable things like changing attitude towards stigma, which is a pretty remarkable thing to do in any learning environment, much less in a virtual one. We also have characteristics that we share with massive open online courses, or MOOCs. We're free. We're limitlessly scalable, hence our being in every country in the world. The ability to go into a course and try it out is low risk, similarly low barriers to entry, low carbon emissions, which we care about a lot, and computerized interactions, of course, as part of what we share with MOOCs as a characteristic. And then there are things that are unusual or unique to NextGenU. The fact that we are this combination, that we are for credit, for free, with our partners at universities around the world. We're competency-based, we're strong and varied in the resources that we bring, and I'll show you a little bit about how we choose our resources. It's an efficient way to learn. There's no need to go to an institution or to be able to go to classes on someone else's schedule necessarily. 103 languages through Google Translate. We're ad-free. We have active educational partners, and I'll tell you a little more about those, and Ms. Chickering will as well. We have a curriculum that's coordinated across all of the courses, and we'll show you a little more about that. It can be asynchronous or synchronous as people desire. We've tested our efficacy, and I'll show you some about that as well. And we have an open research policy so that others may test it as well. These are our founding collaborators and funders. Many of these are organizations that are familiar to you. One might not be the Annenberg Physician Training Program. We hold a $20 million endowment grant from them. I think all the others will be pretty familiar to you, though. And this is how we create our courses. We take existing competencies and we match them with authorized resources. I'll tell you a little more about that in a moment, what authorizes a resource. And then we organize them into modules, create narratives around them, and activities like activities with mentors or peers, if that's what's mandated by a set of competencies, or activities that one might do on one's own. And then we convert them into courses. This is a homepage for our lifestyle medicine course. This is a course that I suspect that many of you in the audience might find quite useful to use with your constituents. But we have quite a number of trainings that I think might be useful for your highly diverse audience. We have a master's degree in public health, which I'll tell you about in a little bit of detail. A pre-health sciences training that includes biology, organic and general chemistry and biochemistry, calculus and physics. We have a med school in a box that is a set of resources only, not a full course, for the 4 years of medical school for North American training. We have available the foundations for preventive medicine residency. That's my specialty. And other areas of graduate medical education, we are beginning to have components of those. And then we have through, as Miriam mentioned, Nurses International, the organization that she founded, we have student-facing and teacher-facing bachelor's training in nursing that is growing quite rapidly as well. So just to tell you a little bit about the Mph program, because that's really our first free degree. It's something that's available for you to do with any of your institutions. We are working with 2 institutions, 2 medical schools in Texas and in New York to implement this Mph program for their medical students as a second and heavily discounted degree that they're giving them. So the Mph curriculum is organized to cover the core courses, of course, and we have quite a range of sample electives as well, shown here, that could be useful either if y'all are interested in offering a full Mph, or for you to integrate into some of your other degrees, or for continuing education training for you and for your colleagues. So you can see many of these have a wide variety of both public health and clinical applications. Right now, we have 150 students enrolled in the program, and this current batch of students come from over 40 countries. We've had students from over 100 countries graduate from the program over time. And this is how we structure the course in the little bit of more detail that I mentioned, and the degree. So again, like all NextGenU courses and certificates, the degree, the Mph, is competency-based, both from North American sources and from other sources. We try to do that with a crosswalk whenever we can, whenever there are existing competencies that are relevant. These are the resources that I said were accredited. They must come from one of these sources, from governments, peer-reviewed journals, universities, or professional specialty societies, obviously medical within medicine, but other professional specialty societies in any of your disciplines are appropriate as well if you're interested in making a course with us. And this is part of what we do for quality assurance. And then, as I mentioned, we have skill building, mentored, and peer activities that are competency linked and that also create global communities of practice. So these are a few samples of some of the courses that we've developed, again, within the Mph. These are the 9 courses that we have been commissioned by CDC to create. We're now on our 12th course that we're creating for either the U.S. Centers for Disease Control and Prevention, CDC, or for the World Health Organization. So just to quickly sort of take you through those so you can see some of the offerings that we have on hand. I'm sure that many of you are sitting there with phones, and if you decide to go someplace during my talk or Miriam's talk or some other talk, or you're sitting having a cup of coffee, please have a deeper dive into these courses if any of them particularly appeal to you. And I'm sure it's branded in your brain by this time, but this is our URL, nextgenu.org. So you can see there's quite a raft of courses. This was the first course that we created for WHO. It's available in a more generic health leadership form as well. We not only created this course for WHO, but we taught it for them. So this is another function that we can do, is do capacity building with you and your faculties and colleagues so that you can teach such courses in the future. So that's what I wanted to show you in terms of some of the courses that we have either now available or subsequently available. This is the residency program that I mentioned. This is my specialty, preventive medicine. And this program, which we're planning to start in Texas with our colleagues there next summer of 2022, most likely, possibly sooner, is a standard 3-year-long residency program, which is in preventive medicine, which is a year of internship, a year for the Mph, which we provide, and a year for the practicum. So I just want to show you a little bit to close my portion of this about our evaluations, both the evaluations that we provide of students and also evaluations that have been done of us. So there's this self-evaluation that students can do, and also peer and mentor evaluations as well. The course evaluation components I'll show you in a moment too, but for self-evaluation, people are given multiple choice quizzes at the end of modules and a final exam as well. And then they're often assessed, depending on the activities required, of course, by their peers and mentors as well. So this is a typical multiple choice question. You get multiple attempts for those. This is one of our final exams, translated into Arabic and timed. These are some data to conclude on NextGenU. So these were the first studies that we did, and you can find all of these data under About Us in the Publications sub-tab on our website. So this is a trial that we did of our first course, Emergency Medicine for Senior Medical Students, and we did this at the Uniformed Services University of the Health Sciences in Bethesda and at Mizzou. And here we were able to look at gains in knowledge and compare to traditionally trained students and find that they had exactly identical knowledge gains, both at USUHS and at Mizzou. And here at Simon Fraser University here in British Columbia, we tested one of the core courses for the environmental health for the Mph, and found, again, identical knowledge acquisition compared to traditionally trained students and superior student course satisfaction. We were able to test that here in a blended classroom application of this course. So those were really encouraging findings in North America, and we have use in North America. We have 74 US med schools that are linked to, their students are linked to our training, students and alumni and faculty, and over 300 universities globally. So here's finally the another large study that we did in Kenya of the mental health related courses. We found a strong preference for our courses compared to traditional courses. We found that the trainees were able to increase their confidence in their substance use disorder care, both their self-efficacy, their perceived patient assessment, their ability to intervene as well. And as I mentioned at the beginning, and to me, even more remarkable finding, that we were able to reduce stigma against people with mental illness and substance use disorders, which is a huge issue, as you may know, not just domestically, but in a lot of low and middle income countries. People with mental health issues are frequently caged, overdrugged, chained. Because people fear them and misperceive them and don't understand how to treat them well. So this was extraordinary for me as a heartwarming finding, that we were able to even achieve a reduction in stigma. And this was, again, from their primary care docs. So just to close with a couple more slides of qualitative data. This is from the Africa Mental Health Foundation, who was our partner on this study in Kenya. And this is from the primary care docs. And you can see that they found the training applicable. And again, this is sort of a qualitative explanation of the reduction in stigma. They didn't see these patients as people who were failures. And finally, from the patients themselves in the randomized control trial, these two pieces of qualitative data are, I guess, two of my favorite pieces of data in the world. One is this patient, Alex, who was able to feed his children and send them to school. And then Grace came in with her husband at the 1-year follow-up for their intervention with their baby in their arms, saying that they'd been able to conceive because their doc had taken our alcohol use disorder training and had been able to help them stop drinking. So that's what I wanted to show you. And I am turning it back over now to Ms. Chickering.
Thank you, Dr. Frank. I hope that some of those discussions around data made you a little bit hungry. This is what can be done with the hard sciences in an online learning environment. Sometimes it seems like it might be easy to teach things like history or other softer subjects, but hard sciences and healthcare can be taught effectively online as well. I just want to go over some of the opportunities that have come up for NextGenU. I'm the shared CEO of both NextGenU and Nurses International, so you'll hear me referring to both as I continue to speak. As Erica mentioned, we have users in every country and 300 universities globally, and these span from San Antonio, Texas, to a brand new Mph program that Dr. Frank is the co-director that started just last month in Cameroon. The 150 students in our Mph program can receive accreditation through a partner university that is recognized in over 40 countries. So there are many ways to develop partnerships over time so that what you're teaching to your cohort, perhaps in the United States or in Canada, can be globally useful. There are also ways to contextualize your content for a global audience. One thing that we do to help with that contextualization is we invite our global partners to participate right from the very beginning: curriculum development, structure of courses, and every piece of the instructional design, ensuring a good fit for all of our global partners. In addition to the current materials available, we have We have alumni from over 100 different countries. Many of them still participate in product development and tutoring our students. They also participate in research. We have a newly founded African Institute of Public Health. We have 3 online research labs and work together to help our students and our colleagues and partners publish regularly on the successes that they have when we do our collaborative projects. We also are working strategically country by country to achieve good penetration of materials. We just partnered with a university in Pakistan with 1.4 million students, and they will be offering our courses for credit for free to all of their students, which is a huge win. And then we also partnered with the second largest university in Pakistan, offering a suite of courses as well. We find that these partnerships can be extraordinarily deep and collaborative. It's very easy once you have an asynchronous course that's very robust to work with partners in a half-day online meeting and develop a plan to contextualize that course. It can be done over a period of a week or 2. So you can truly take what you've created for your audience and with a little bit of help, make it available globally. There have been some significant challenges to offering science courses in an online environment, particularly healthcare courses that have a clinical component. So I want to talk for a moment about how we handle those clinical components. Clinical components are always regulated by local governing bodies. So at Nurses International, we have a skills list of over 100 nursing skills, and we'll link to videos, we'll create rubrics and forums so peers can meet and watch each other practice those skills. But eventually, that nursing student needs to meet with a licensed nurse at her local school or someone that she's been assigned at a local healthcare institution to check her off for that skill. And when she does do that check off, she needs to do it according to the facility's policies and procedures where she's at. And she needs to make sure that she's practicing within her scope of practice for that country. All of these things vary, but again, this variance is completely managed by the collaboration between our team and the institution that's bestowing that degree. So for clinical courses and degrees that have clinical components, they need to be co-offered with a collaborating partner who's on the ground. Another thing that I think is really important and different about our model is we give our materials away for free to our partners. So our partners may then charge for those degrees, and that's part of our mission. We're completely happy to do capacity building in that way. We have a really wonderful partnership where we take our students through our Master's in Public Health degree program. They can then matriculate to one of our partner institutions for a PhD. And so it's very valuable to begin to build these professional ladders in different disciplines and collaborate with partners who maybe they're missing a rung in their ladder, and maybe your organization can help fulfill that. And if we all start doing that together, I think that we're going to see incredible outcomes over the next 5 years in the healthcare sector globally. It's past time for sector disruption and getting rid of the bottlenecks where we can't seem to, where we have profound shortages of healthcare workers. I think one of the big lessons from the pandemic is that those shortages of healthcare workers are unnecessary because the cost of education can be managed very well and in ways that it has never been able to be managed before through open educational resources, through sharing agreements, and through digitizing education. Now that education can be digitized, it can be, to an extent, demonetized, and then it can be democratized. There are some other challenges that I'd like Dr. Frank to speak to. How does NextGenU take the information shared by subject matter experts and present it to students in a way that creates adequate knowledge transfer that equals or succeeds what they would experience in a traditional learning environment?
Yeah, so I started NextGenU after having spent my whole life since age 15 in the embrace of a university, and in some of the fanciest universities that the US has to offer. And in fact, it was shortly after I finished my 3-year fellowship at Stanford that I thought of this idea for NextGenU, knowing that we could take materials as all of us around the world have done this last year because of COVID, and make them available online, embedded in an educational environment that could be highly stimulating and successful for students. And so we've been able to produce courses of various sizes, both skinny versions where it is useful for a particular set of competencies, for, let's say, a community health worker or someone trained at the master's level. Our substance use courses and mental health courses are a good example of that. And then we also produce larger versions in more depth and at higher levels for folks with terminal degrees who want to have a more thorough understanding. And then the testing that we provide, as you mentioned, is corresponds to that. So we use, as I showed in my data, both questions that we've created to correspond to competencies, but also ones that colleagues share and help us create that correspond to the kinds of testing, and sometimes are the kinds of testing that are used nationally. So, for example, on the emergency medicine course, that was the knowledge gain was tested with the standard shelf tests that all junior medical students take after they finish their clerkships.
So I'm going to extrapolate from your answer something that might be considered controversial. And that is this skinny version or this text-based online learning program is really not what we're reading about now. What we're reading about are these highly specialized instructional design programs, certificates that are crafting this online environment. And I have to say, at great cost. So instead of a course that takes a subject matter expert who's also an academic expert perhaps a few weeks to create, it may take them months and cost them thousands and thousands of dollars. What would your advice be to educators who are confronted with this conundrum of, do I need to go out and become an instructional designer to do online learning?
No, come play with us, right? This is the kind of thing that Miriam and I do all day long. And just for you, dear audience, to know, this was a surprise of a question, but I'm sure to you, not a surprise of an answer. We, as I mentioned, are being used through 74 US med schools. We have direct relationships for, as I mentioned, the full master's in public health degree with 2 US med schools, and work with a number of health professional schools domestically and globally to collaborate, to work with our instructional design team to come with your subject matter expertise and work with our team to do this assemblage of resources and then creation of an interactive, engaging course around it. I know that everyone in the audience who has been teaching it all for the last year has been struggling with this, and it's been both sad and frustrating to see people struggling with this, as you mentioned, and spending months and millions on it, but also exciting because it's a place where we can really be helpful and remove so many of the barriers. Just to be really specific, our partner in Texas for the Mph has been able to offer the Mph for a sixth of their usual cost because they don't have all of the course prep nor as much necessarily of the course interaction. So it's extremely affordable for them to be able to expand their course offerings.
So we're talking about this low barrier entry to online education. But when you talk about a low barrier to entry or cost controls for online education, of course, the question comes up about quality. So how do you achieve high quality with controlled costs?
So as I mentioned, I did my training at extraordinary institutions, which I am very grateful for. And then I was able to go on to be faculty at also outstanding institutions and got to practice being both a student in multiple spheres and a faculty member. And the components that I showed in that first and last table of characteristics of NextGenU that are important for being able to have accessible education, I knew that we could achieve those. I knew that we could, by using existing online resources and embedding them in meaningful narrative created by subject matter experts, and having useful interactions, that was how I learned at the fanciest of institutions. And just because we're doing face-to-face remotely right now, you, dear listener, and me, it's still face-to-face. It's still interactive. And in a moment, we'll be having interactive questions to demonstrate that as well. But just in terms of quantitative ways that we demonstrate excellence, again, these students are needing to take the same boards, the same tests that they have in the past, and the educational institutions that we're working with, of course, have their students' passage of those tests as their most critical outcome, no matter what learning modality they use. So that's really the ultimate insurance, is that the organizations that we work with, their students are passing their exams.
With the current environment, particularly in the for-profit education sector, the emphasis is on student satisfaction, not just passage rates. How does online learning affect student satisfaction?
Well, you saw the data that I showed from the two formal studies that we've been able to do of that, one in Canada, one in Kenya, showing superior student satisfaction. And there are some things that students don't like about doing online education, and we've all heard about them quite copiously this last year. But there also are many components that they love. The fact that it can be done with both synchronous and asynchronous components. The fact that it can be done within that asynchronicity on their own schedules, that they don't have to travel, that they can continue with their job and their family obligations and their other obligations and be able to do this kind of education from their home. And of course, that it's affordable. This, like I said, has made it possible to give away education in many places and to provide it at profoundly discounted costs to learners, because it's at a profoundly discounted cost for the teacher. They're handed a course, and that's a pretty nice place to start from in terms of how much investment you have to make in teaching.
For academicians, often accreditation is linked to that educationalist participating in the content creation. How do you accommodate educationalists who need to, for accreditation purposes, co-create content?
Our purpose at NextGenU is to democratize education, and that means working with both individuals, where we hand them individual courses, and working in partnerships with universities and specialty societies, such as many of the organizations that y'all represent within the Health Professions Network. So could you tell us about the process that you developed for us at NextGenU and how you're making all of this happen?
I love working directly with educators. It's thrilling, particularly when we're working with educators from 3 or 4 countries at the same time on a course to contextualize it. So once we have that maximally robust version that can be taught in a completely asynchronous environment, it's not that hard. You just sort of unwind to create contextualized versions that are highly specific. You can even get as specific as what's happening at a particular hospital and how you incorporate their protocols. And then you can crosswalk to their Ministry of Health or Education's competency set and do some restructuring of the course. Usually it just takes a few weeks. One of our university partners frequently comes to us 4 to 6 weeks and says, we need these 2 courses. They have to meet our syllabi requirements. And we get it done. Our team is incredible. Our team is from 7 countries. And it's lovely to have people on our staff who are from these different countries. When we do crosswalks, we often try to include peer-reviewed literature from the locations for which we're creating the materials. And one time I was complaining to our team, our literature is not diverse enough. We need to hear more of the voices from these mid-income countries. And one of my team members is like, Miriam, I am from a mid-income country. I am the subject matter expert. It's okay. We know what we're doing. And so it's important when you're teaching to a diverse audience to actually have members from that diverse audience creating those materials, not just externally as subject matter experts and consultants, but internally on your team. And so that's what I would encourage institutions to do. So many of our institutions have a global audience, and you have students, maybe they're coming to the US or they're coming to Canada, but they're from all of these other countries. Well, guess what? There are orthopods in a lot of countries, and you can include those experts in your curriculum creation, and it's appropriate to do so, and it benefits everyone in the environment to do so, whether you're charging for your content or you're giving your content away for free. So, Dr. Frank, one of the big problems with online learning is increased attrition rates and students not completing courses. What are some of the best interventions to help students complete online courses?
So we find what most people find, that when an individual tries to make it through a course on their own, it's really hard. And when a classroom goes through a course, we get essentially 100% completion rate. So creating a supportive cohort, whether it's a formal classroom or something else, is a particularly good technique for getting through these kinds of courses.
Yeah, I couldn't agree more. It's not just, that's where the synchronous components with video are so important, or even asynchronously communicating with students. Every student needs to have one person within that course that they feel some sort of a connection to. And we found that teaching courses mostly asynchronously with a few synchronous sessions via video is highly effective, even when we're teaching public health workers who are slammed in the middle of a pandemic, like we did this year with a cohort from the Caribbean, our pass rates, our completion rates were extremely high. And that's because of that connection that the students had with Dr. Frank and with the other facilitators and with each other in the course. I think another component that's really important to discuss when organizations are considering putting their knowledge online and sharing it is paid versus unpaid. So in the space, there's so much out there now that it can be difficult to build a paid cohort or to sell courses unless you're doing it through a big company. And unless you're giving away some sort of accredited degree. Students will pay for degree programs that get them into the job market and are less likely to pay for other courses that don't affect their workplace or their ability to get into a workplace. I want to make an argument for free online education. And the reason I think that this is a effective strategy for our listeners is that building free courses that lead to certificates that can get people into the workplace or get them into the healthcare setting, it does good for everyone, right? It does good at scale, and you start getting to scale, and where you're really able to make an impact. And there are ways that you can give away really important information that the majority of people in a discipline need. And you can still keep some of it that's specialized and charge for that. So I would just encourage you to not just give away a webinar, but really consider giving away at least an introductory course to whatever your specialty is. It's an amazing way to build your network. It's a great way to build your membership if you have a membership. And it's a great way to bring people to your profession. If there's a shortage, if you're experiencing a shortage in your profession, give them a taste of what it's really like, not just through a webinar again, but through a whole course. And that builds so much confidence that if they're able to complete an introductory course, maybe they'd be able to complete a certificate or a degree program. With online learning, Erica, I'd like to talk for a moment about an alumni network. How do you simulate an alumni network through an online learning program?
Well, part of how we've started to do that is to provide collective activities, like a journal club, for example. We're right now running a journal club every other month with the South African Medical Association on evidence-based medicine. And this is an opportunity for our alums across several professions and multiple courses to come together and participate and to continue to be connected. So again, this is a place where the pandemic, for all of its horrors, has left us with a legacy where we've figured out, I'm sure you've figured out, participant, not just Miriam. I know Miriam has figured this out, but you also have figured out how to connect ongoing with your colleagues and your students and bringing them into these kinds of actually useful functions as opposed to frippery that is offered to engage alumni to make donations can really be a very solid way to make sure that people stay engaged by giving them activities to do together that advance the mission that you have inculcated in them.
Because our education is either free or for very, very low cost, we teach our alum that their mission is to go build more public health programs. Their mission is to get a job at the Ministry of Health and really make a solid impact. And so many of our alum now participate as tutors and module leaders within our programming, course creators. And so every student that graduates from one of our courses or programs then becomes part of our network of people who are on mission with us together. And so you just never feel alone. You have this huge family of hundreds of people from all over the planet that are working together to promote public health, to improve global health, and to increase the number of healthcare providers. I think the last piece, Erica, that we should talk about for a moment is the potential. And one of my mandates for both NextGenU and Nurses International is to think long term. What do we want to see over the next several decades? And one of the big issues and the opportunities because of the pandemic is the disruption that's been caused. And how do we leverage that disruption to apply existing technologies, maximize their benefit for everyone, so that we can meet the SDGs, so that we can really achieve the potential that comes with these new technologies. And one of the things that we've identified is a suite of interventions that seems to have been effective, as being effective in public health. We're beginning to see the impact in nursing and in medicine. And Eric, I wonder if you'd talk for a few moments about that suite of interventions.
This is the moment to democratize education. This is the time where we and all of you are able to say to would-be learners, we have a medium where we can transfer an awful lot of knowledge and skills to you directly with very few barriers of time or of cost or of geography. With partners offering locally degrees and support for learning as well. And then also directly accessing the Mph program that we offer for free or at very low cost. These three kinds of approaches of individual low barriered learning, of collective learning with your local institutions, and of learning through us, together have the potential, with the lessons that we've all learned over this last year, to completely democratize education. And given that you talked about the SDGs, about the Sustainable Development Goals, given that education is one of the most important predictors of health, much less health education to create health professionals, democratizing education is one of the most essential activities that we can do to meet the SDGs.
Thank you, Erica. And one more important thing for our listeners is not only is there tremendous potential for impact, but there's tremendous potential for your specific organization as well. You can leverage your knowledge sharing to create a marketing funnel to increase your networks and bring more traffic to your website. Because you'll have more people using your product, you can create feedback loops and gather data to make it even better. You can publish that data and contribute to the body of educational research that's being done on online learning. And you can use your organization's mission as a clarifying lens. What are you supposed to be doing in the world? As a leader of your organization, what's your mandate and how are you going to achieve it? And one of the best ways to achieve an organization's mandate is by expanding your audience and sharing your message. And online learning is an amazing way to do that. It's easy, it's not expensive, it's low barrier, and it will help everyone in the world. Thank you.